Welcome to NDARC's weekly webinar. I'm Alice Havard, a Senior Research Fellow at NDARC, and it's my pleasure to be hosting the webinar today. I would like to begin by acknowledging the Wangal people as the traditional custodians of the land from which I'm joining this meeting. I would also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across the country. We pay our respects to the elders past and present and extend that respect to any First Nations people present today. Now, it's my real pleasure to introduce today's speaker, Associate Professor Julia Lappin. Julia has academic positions at both NDARC and UNSW's School of Psychiatry, where her research focuses on improving outcomes for people living with psychotic illness. Julia is also the Clinical Director of the New South Wales Tertiary Referral Service for Psychosis. In today's webinar, Julia will be providing an overview of the role of stimulant drugs in inducing or aggravating psychotic experiences and the clinical implications of this relationship. I'm pleased that during question and answer time, we'll have the opportunity to hear from Professor Shane Dark from NDARC. Shane, who has been with NDARC for over 30 years, is a world leader in research on the health effects of illicit drug use. Julia and Shane will take questions from the audience after the presentation. You can log questions for them using the Q&A function. Please use the Zoom Q&A function rather than the chat. And I will relay as many questions as possible to the speakers at the end of the presentation. Julia, I'll hand over to you now.
Thanks very much, Alice, and thanks for the warm welcome, and hello to everybody. As Alice said, I'm going to talk to you today about psychosis and stimulants. So before I start, I'd like to just make an acknowledgement of country. So I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people who are the traditional custodians of the diverse countries from which we're joining the meeting today. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging, and extend that respect to Aboriginal and Torres Strait Islanders people present today. And I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families or supporters. So I've provided a brief outline of today's talk. I'm going to move through reasonably quickly, first with a brief introduction to psychosis, then stimulants, and then trying to understand the biological link between them, then look at some of the epidemiological evidence of increased risk for psychosis associated with stimulant use. And I'll finish for the last sort of 15 minutes of the talk on work that's really relevant to me, which is the clinical implications. I work both as a researcher and as a clinician, and in my clinic where I see people with psychosis and psychotic illness, there's lots to be learned from research, lots to be learned from the clinic that can also inform research. Okay, so let's start by thinking a little bit about what we mean by psychosis, psychotic symptoms, and psychotic illness. Psychotic symptoms take a number of forms, and it's easy, I think, to think of them largely in terms of positive symptoms of psychosis, negative symptoms of psychosis, cognitive symptoms, and others. Positive symptoms are probably those that most lay people would associate closely with psychosis. So things like hearing voices, believing things to be true that other people don't believe to be true, despite evidence to the contrary, often with a bizarre or persecutory or paranoid flavor, and that's what we call a delusion, a fixed false belief. There can also be thought disorder, which is disorders of thinking, cognition, and memory, and odd or unusual behaviors. Negative symptoms, in contrast, reflect really the absence of experiences that we would typically expect everyday functioning adults to have, and therefore there's a loss of the ability to have motivation, have interest in other people, whether socially or sexually, have low mood, low energy, and low emotional connection with others. The cognitive symptoms of psychosis can often be overlooked, but they can be very impactful on day-to-day life for people. They can affect attention, verbal learning and memory, reasoning and problem solving. There are also socio-cognitive deficits that are associated with psychotic illness, and these relate to people's ability to interact with others, often less able to correctly attribute emotion or correctly recognize the intentions of others, and that's theory of mind. It's often overlooked that with psychosis and psychotic illness, that's a severe mental illness, there are also comorbid, very high rates of anxiety and depression, to the extent that these rates are so high that they're almost part of the illness, and that comes with all the negative consequences of the psychosis, gives rise to depression, feeling constantly that you're being harassed or persecuted in itself could lead to high levels of anxiety, but also anxiety around self-esteem and other issues. There are high rates of suicidal behaviours, and that's across the spectrum of psychotic illness, but would be even more prominent in people who have a psychotic illness with a prominent affective flavour, such as bipolar affective disorder with psychotic symptoms or psychotic depression. And importantly, the affective symptoms can be targeted by cognitive behavioural therapy and other mechanisms whereby people can learn to manage their experiences and symptoms better. And while we may not be able, in some cases, to stop people hearing voices or experiencing delusions, we can, through these mechanisms, reduce their worry and their anxiety about those experiences and improve their quality of life. So I've talked a little bit about psychotic symptoms. Many people can experience psychotic symptoms transiently or over a more continuous period. And that's an important distinction when we're thinking about psychotic symptoms or psychotic illness in the context of any substance use, but for today's purposes, stimulant use, because really we need to think about how long these symptoms are lasting and whether they're self-resolving. That's really important for us to understand to what extent substances may be contributing to ongoing problematic mental health for people. So I just have included this slide so that we can think carefully about psychotic symptoms being somewhat separable from psychotic illness. Psychotic illness is where those signs and symptoms of psychosis are present almost continuously. That means most days at least, for around 1 month. And importantly, they're associated with significant distress and impaired function. Subtypes of psychotic illness, which you may be aware of, psychosis is an umbrella term, and underneath that are the diagnoses most commonly of schizophrenia, schizoaffective disorder, or affective psychosis such as depression or mania. All right, so we'll move on now just to think about what do we mean by the term stimulants. And today I'm going to focus mainly on methamphetamine and amphetamine, also cocaine. MDMA is a psychostimulant. There's very limited evidence base for associations with psychosis and particularly with psychotic illness. So I'm not going to spend very much time thinking about MDMA today. The psychostimulant group is an important, really leading problem in the world today. Global use of psychostimulants, we know, is increasing. We know that recent statistics show us that 27 million people have used methamphetamine over the past year, and cocaine not far behind, 19 million. So methamphetamine is well known to many of you as crystal meth or ice. Crystal meth is a more potent form of methamphetamine. Importantly, the active metabolite of methamphetamine is amphetamine. So when people talk about amphetamine or methamphetamine, essentially once they're in the body, amphetamine's quickly the active product in the blood, but methamphetamine is a synthetic form of allowing amphetamine into the blood system. So meth has been produced in various forms since the 1950s. It did enjoy a period of being legal. Now it's largely illegal, although of course we can access amphetamine through some prescribed treatments, and we'll come to talk about that a little bit later in the talk. Now, approximately 95% of illicit amphetamine is taken as methamphetamine. And some of the general characteristics that we know about methamphetamine users are that approximately 2/3 are male, majority of users in their 20s and 30s, as is true for many illicit drugs, and that methamphetamine users participate in different patterns of use. So there may be daily or at least once per week use, which can be associated with dependence. Non-dependent use would be people who are using less frequently than that. We often see sort of binge patterns of use approximately fortnightly or intermittently, and it's less likely that people would have dependence in that sort of use pattern. So as I've mentioned, crystal meth is something that we're all very aware of. What does it really mean? Well, it's methamphetamine, but it's a high potency crystalline form, which gets into the blood system very, very quickly. And we know that these high potency drugs are more likely to lead to dependence because of the very quick association, the very quick period of time between the drug coming on board and experiencing the effects. It's also the case that the very high purity of drug that is present in crystal meth drives dependent use. Again, because people are getting high dose of active drug into their system quickly. For most rapid action of the drug, we know that it's delivered fastest into the blood system by injection, also by inhalation or smoking. And by these mechanisms, it rapidly reaches the brain with almost immediate onset of its effects. If you snort or if you take pills as tablets orally, the effects will come more slowly, usually within about 20 minutes. Well, what about cocaine? It's another psychostimulant. Current production of cocaine is at its highest level recorded in modern times. It's also got a high potency form known as crack. And again, that high potency crack is associated with more harms. More harms are really associated with high purity, high potency, and dependence is highly associated with those factors also. Again, as I've said, as is the case for most illicit substances, the characteristics of the group of users is that around 2/3 are male, and again, the majority in their 20s and 30s. So I'll move now to really the biological link between stimulants and psychosis. It's important to recognize that many substances are used by people who have psychotic illness. And it's a bit like the chicken and the egg. Well, which causes which? It's, I think, more complicated than one directional. We'll have a look at some data which support the idea that there are multiple explanations for the high rates of comorbid psychosis and substance use that we see. But dealing So I want to make the point that while we're focusing on psychostimulants today, a lot of these relationships are somewhat true also for alcohol, cannabis, and hallucinogens. There are higher rates of psychotic illness among users of all of those substances also. Particularly focusing in on psychostimulants, we know that there is good rationale biologically for why psychostimulants may both precipitate and maintain psychotic symptoms in users. Indeed, way back into the 1950s, biological models of psychosis relied on psychostimulants as a mechanism by which to study psychosis induced in healthy volunteers by giving them amphetamines. And the next slide shows a little bit why that's the case. So both cocaine and methamphetamine block the reuptake of the neurotransmitter in the brain known as dopamine. And you can see in my little schematic there that cocaine is the red T-shaped sort of schematic, which can block the blue receptor. Now that's important because for those of you who don't really understand about neurotransmitter biology, what's important here is the amount of neurotransmitter out there in the free space, the synapse between the presynaptic and the postsynaptic nerves. While that dopamine, the neurotransmitter, is hanging around in that synapse, it's active. And what we know about psychosis is that there is hyperdopamine activity. We call it a hyperdopaminergic state. Dopamine is your neurotransmitter for motivation, for coincidence detection, for alert, and for reward. When you're in a high dopaminergic state, as can be induced by release of extra dopamine and blockage of dopamine being able to come back in, such is the case with cocaine and methamphetamine use, then you've got extra dopamine, people are hyper alert, people are hyper vigilant, people start making connections where there might not be any. And this is exactly the state of the brain when people are experiencing emerging psychotic symptoms, making connections where they aren't there, seeing links where there aren't links, can lead to delusion formation. The brain makes mistakes about whether a stimulus is detected inside or outside the brain. The brain starts to believe that it's detecting voices or sounds outside the brain when in fact it's likely to be due to an internal circuitry issue. So in 2 minutes, that's really how we understand the development of psychosis to occur in the brain of anybody due to dopamine overactivity. When you have cocaine and methamphetamine on board, they allow that dopamine overactivity to be the natural environment for much longer than would typically be the case. And as I've said there, just the final point, back in the day, back in the 1950s, dopamine agonists were used to induce psychosis in healthy people. And this was part of how we understood the importance of dopamine in the development of psychosis. I've summarized that here. Models of schizophrenia, that's one example. So schizophrenia, again, comes under the umbrella of psychosis. It's the most severe and chronic form of psychosis, and that's why we focus here on schizophrenia, but this is true for all forms of psychosis. So models of these illnesses suggest that repeated exposure to a dopaminergic stimulus gives rise to the hyperdopaminergic state. And importantly, this may induce psychosis in vulnerable individuals. So I want to come back to this point, but I will just make it for the first time here. Not everybody who was part of the experiments in the 1950s and subsequently, not everybody developed psychotic symptoms under the conditions of increased dopamine in the brain, but most people did, about 75%. Some people experienced it very early and very quickly. Others needed higher doses. And this is actually mimicked in what we see in epidemiological studies of psychostimulant users experiencing psychosis. And I'll come to that in the next section. But it is valuable, I think, to consider that different people have different vulnerabilities to the development of psychosis. The lucky ones may never develop psychosis, no matter how many stressors, how much dopamine they are exposed to. Other people who are very vulnerable, perhaps by dint of a family history or other neurodevelopmental factors, which are true for all people developing psychotic illness, those people may develop psychosis with just one stressor, and that could be just one use of methamphetamine. Of course, it can also happen for people who don't drug use at all. But the point is, it's helpful to think about a variation in vulnerability to the future development of psychosis. We know that stimulants increase synaptic dopamine, and therefore that they serve as a risk factor, particularly in people who are vulnerable to the development of psychosis. Importantly, there is also an interaction with personal vulnerability, which could be typified by family history or schizotypal traits or developmental issues. And the frequency of substance use will also increase your vulnerability. So hopefully in that whistle-stop tour of the neuron, I've explained the biological basis of the link. And now I want to move on to look at the epidemiological evidence of increased risk for psychosis among stimulant users. So there have been many studies conducted over years, and Rebecca McKeaton, who works at NDARC, has done a lot of really valuable work in this area. And Rebecca and others' work has shown that among methamphetamine users, the 12-month prevalence of psychotic symptoms is about 80%. So most people who are using will have psychotic symptoms from time to time, but again, not everybody. Some people are really not vulnerable to this, and lucky them. Yeah. What Rebecca's work also showed was that if you use higher dose, or you use more frequently, or you're dependent, which is a sort of proxy for those things too, then you're more likely to experience transient symptoms. So that's psychotic symptoms. Let's move up the hierarchy of severity to get to psychotic episodes. So this is periods of psychotic symptoms which last much longer and last beyond the time when we expect the substance to have naturally sort of been metabolized from the body. So psychotic episodes are much less common, as we'd expect, because that's the higher bar, but they're still pretty common. So in the general population, psychosis is, we say, rare in incidence, but more common in prevalence, because once you get it, unfortunately, many people continue to have it. So it's about 1% in the general population. Among recreational methamphetamine users, 13% are having drug-induced psychotic episodes, and 27%, 1 in 4 dependent users may have a psychotic episode. So these are very high rates compared to the general population. We also know from other work that in people who, so looking instead at the psychiatric population, so Rebecca's studies looked at a mental health, a drug-using population. If we look instead, this is the third bullet point, at a clinical population of people with mental health problems, people who are in the early stages of psychotic illness, we see that they have quite high rates. Stimulant use, 15 to 30% of them are using stimulants. And that's again evidence that the two phenomena overlap. I'll come to that last point later in the talk. And again, just showcasing some of Rebecca's work. Really, in summary, we know that there is high prevalence of psychosis in methamphetamine users and reasonably high prevalence of psychostimulant use among people with emerging or early onset psychosis. We also know that the psychotic symptoms observed in methamphetamine users are dose-related, and that's important because if things are dose-related, that contributes to the evidence suggesting that there may be a causal link. So in summary, psychotic symptoms are more frequent with regular high-dose or dependent use. And certainly for some people, psychotic symptoms don't immediately resolve. Again, this is the idea of this transient symptoms may be a direct effect of substance use. But what about the people for whom those symptoms stay? It's no longer the direct effect of the drug. Those symptoms linger. And by dint of someone really experiencing a psychotic episode in the context of substance use, it's helpful to think about that person having a vulnerability to develop psychosis because they've demonstrated that vulnerability by having a psychotic illness. Now, one of the very important things for us as clinicians to do is say, well, to what extent does the drug contribute to the development of the psychosis? Someone may have a family history of psychosis. Someone may have other stressors going on in their lives. They may have neurodevelopmental factors, minority status, all of which are risk factors for psychosis. The substance may have triggered a psychotic episode in someone who was already highly vulnerable. Alternatively, this may be someone with none of those known risk factors for psychosis, but who has somehow tipped over into the threshold for psychotic episode, perhaps because of very prolonged, heavy, dependent, high-potency use of the substance. I think what it's helpful to do is think of the substance as part of the milieu that is giving rise to the development of psychosis and not trying to be too linear about it and saying, well, it was due to the drug. We know that the drug was part of the picture. It may be a big part, it may be a small part. Actually, what we need to do is track the person over time and see to what extent they can recover, perhaps with abstinence, perhaps they can't abstain, perhaps they'll recover anyway, perhaps they won't, even if they do abstain. So we need to take a longitudinal view. And this is the question. The million-dollar question is, does methamphetamine cause psychosis? Could methamphetamine give rise to psychosis in someone who never otherwise would have got it? In honesty, we don't really know. We know some of the risk factors for psychosis, but we don't know all of them. Sometimes people develop psychosis where they don't have any family history. They may have had a stressor like a relationship breakdown or a new baby, and it's come really very much out of the blue. That can happen in drug-related psychosis too. And there is this sort of natural tendency to sort of make a link with the recent drug use and say, well, it was due to the drug. And again, there's some evidence we know for certain that there's a biological link for the development of symptoms, but whether that leads to permanent continuous illness for any given individual, again, we need to track that over time. There's some evidence from Japan where there's been many decades of methamphetamine use, that methamphetamine-associated psychosis is associated with more frequent methamphetamine use and longer duration of use, and also that people who abstain for many years and don't use methamphetamine can have relief from their psychosis, but if they use again, they can have the psychosis reactivated. And it seems that there may be some kindling effect, a bit similar to what we see in epilepsy, so that smaller doses and even smaller non-drug related stressors can precipitate psychosis in these people who may have become more vulnerable to psychosis. I think that's the important thing that we haven't quite worked out yet. Can a period of use of methamphetamine permanently make you more vulnerable to psychosis than you previously were? I don't think we know the answer to that yet. Essentially, for cocaine, the patterns are similar, but less strong. So psychotic symptoms are associated with cocaine use and dependence. Again, with crack use, there can be a very acute onset of psychotic symptoms, but the risk appears to be somewhat less frequently seen and less often permanently a consequence for users of cocaine compared to users of methamphetamine. And there's less evidence that MDMA gives rise to persistent psychotic illness, and that's why I'm not dealing with it terribly much today. I do just want to make this point also, that it isn't just about illicit substances. If you take amphetamine into your body, whether it's prescribed or whether it's illicit, it has the same mechanism of action. It's the same drug. And we actually know now from a really large and important study conducted by Lauren Moran in the States, that prescription of amphetamine for ADHD among adolescents and young adults is associated with a significantly greater proportion of individuals developing a new onset psychotic episode than is prescription of methylphenidate, which is the other non-amphetamine medication that's often used in the treatment of childhood and adolescent ADHD. I think it is really important for us to hold that in mind when we're prescribing. We really have to think about the possible consequences of introducing this active, psychoactive drug, which really impacts on the neurotransmitter system in the young developing brain. Okay, so as promised, I'm just going to spend the last section of the talk thinking about what are the clinical implications of this biological and epidemiological evidence of a link between psychostimulants and the experience of psychotic symptoms or psychotic illness. So first of all, we need to think about the idea of a drug-induced psychosis. I struggle with the term drug-induced psychosis because I feel that people therefore understand that it's a sort of direct causal link. The drug caused my psychosis. People have come into my clinic and said, yeah, the drug caused it. It was drug-induced. I'm not going to use drugs again, so I won't get psychosis again, so I don't need to come back and see you. And look, for some of those people, a small proportion, I think that may be true, but for most, we actually simply don't know. So the person sitting in front of me may have had a psychotic illness induced by substance, but he may have other risk factors, which mean that he was always going to get psychosis anyway. But we can't know that because we don't have a clock that can go back and let us look and see what would have happened if he'd never had that, methamphetamine. I think it's better to say that you have a drug-related psychosis. So again, it comes back to this idea of the milieu. So we know that the drug impacted, we know that you have a vulnerability to psychosis. We really now need to watch and wait and monitor and see what happens next. And I've sort of summarized that, but this is what's the value of the term drug-induced or drug-related psychosis. What we should be doing is saying this person was using substances and developed a psychotic episode. Importantly, we need to think about them moving forward, being vulnerable to future psychotic illness episodes, may or may not be in the context of substances. Good advice would be stop using your substances, but we can't promise that that will result in no further psychotic illnesses. Indeed, we've got quite a lot of evidence that shows us that drug-related psychoses are not benign, and they are not one-off for a proportion of people. I think I have that slide coming up. Here we are. So this slide shows how many people with different types of drug-related psychosis will over, excuse me, the subsequent 8 years develop schizophrenia, which is your poor prognosis, chronic, enduring psychosis. We can see that it's actually quite high for cannabis-related psychosis. It's about 40% of people with a cannabis-induced psychosis will actually, over years, come to have a chronic psychotic illness. For amphetamines, that's your next highest. So it's about 25% of people. 1 in 4, 1 in 5 will develop schizophrenia after an amphetamine-related psychotic episode. And again, this is an episode, not transient symptoms. Myself and colleagues here at Prince of Wales and Grant Sarah at Inform supervised Ben Murray, who was a University of Sydney medical student, to conduct this systematic review and meta-analysis looking at this question of the transition of substance-induced or substance-related psychoses to chronic long-term schizophrenia. And we found in a meta-analysis of all studies that have been conducted over many years, that last slide was a very big study from Scandinavia, and our meta-analysis confirmed really the findings from that study, that the transition rate does depend on the substance. Amphetamines, 1 in 4 to 1 in 5 of people with drug-related psychosis will later develop schizophrenia. This is important because often care is not provided in mental health services or early intervention services to people with a drug-induced psychosis, because people reason that it was due to the drug. It's not real psychosis. And I think we've got a lot of evidence now to say that that's not supported, and that we should be seeing these people as vulnerable to the future development of psychosis, and really assertively following them up and ensuring that they don't develop future psychotic episodes or symptoms, and if they do, quickly responding to that and treating. I've talked to this point, I think, adequately. I think this is a really helpful way to think about what's happening in the interplay between substance use and experience of psychotic symptoms and psychotic illness. Is how vulnerable are you to develop psychosis when you use one substance or another? Think of substance use as a stressor. The stress diathesis model of psychosis is that any stressor can increase your risk for psychosis. And it's this sort of the double hit theory where people have a certain vulnerability, other stressors come in, tip you over. We should be thinking of substance use as one such stressor. Other stressors exist, like childhood trauma, relationship breakdown, major life events, all sorts of things. Substance use, I'm not sure whether we should see it as being particularly special. We need to think about it as being one of a number of stressors contributing to the development of psychotic illness. All right, I'm just going to check how I'm doing for time. I just want to take you through a few additional clinical implications from this work. I recently, together with Prof. Shane Dark and Mike Farrell at NDARC, wrote this editorial for the ANZJP talking about the risk for development of psychosis with prescribed drugs. We talked a little bit previously about amphetamines and drug treatments for ADHD. And there is recently, you know, we had the decision in June, July that there could now be prescription of psychedelic treatments and others for treatment of certain mental health conditions. And I think we need to be conscious of the ability for some of these drugs, which do have the ability to trigger or induce psychotic symptoms. We do need to be cautious about the prescribing of these treatments to people who may have a vulnerability or indeed an already existing psychotic illness. This is the wonderful paper in the New England Journal of Medicine that Lauren Moran and her group led, showing the evidence that amphetamine treatment for ADHD gives rise to much higher rates of new onset psychotic illness in children and adolescents than does the next most commonly used treatment, methylphenidate. And just a few other clinical points to make before I finish up. When we're thinking about methamphetamine-related psychosis and seeing someone coming in with psychotic illness in the context of methamphetamine, we should see that as an opportunity to intervene if the person's willing, of course, and try and provide education around this idea of a vulnerability to psychosis, that stopping drug use is the one thing that we know makes a difference for groups of people. We don't know if it makes a difference for individuals, but what we do know, I might have this as the next slide, is that people who, having had a psychotic episode, people who stop drug use are much less likely to have a relapse within 2 years than people who don't stop their drug use. But both groups still have high rates of relapse. All right. A few final points are, how do you look for psychotic symptoms in people who have substance use? You ask about these things, ask about hallucinations, persecutory ideas, grandiose ideas, change in behavior, change in mood. And think about, is it an acute effect? Is it a short-term effect that has happened just within hours, 24 hours, days of substance use? Or is it a chronic effect? Are the symptoms persisting beyond the period of acute effects of use or intoxication? Are there symptoms between periods of use and the symptoms are lasting for longer? Because that's really starting to point much more now towards psychotic illness. And I've covered off that point. This is just how to ask about things. I very quickly want to cover this point, which is that it does go in the other direction too. This great study, again from a Scandinavian huge data source, showed us that while we know there's the link between people using substances and developing psychosis, we also now know that it's true that many people who develop psychosis with no substance use over the subsequent 10 years, at least, can develop a substance misuse problem, probably because their lives have really been on an absolute roller coaster and they've become very disabled and socially excluded. So the high rates of comorbidity that we see among people with mental health and substance use problems can go in both directions temporally. Okay. And this is a great slide. This is the one that I mentioned. If you look at the bottom line, you see people who had a drug-related first episode psychosis, who stopped their drug treatment. In the next 2 years, 2 out of 5 of them will relapse. That's the proxy for a readmission. But in the top dotted red line, people who continue their substance use, 2/3 of them will relapse. So stopping substances may help a bit. All right, I think I'm going to stop there because I've run slightly over time. And if there are people interested in the clinical implications of substance use, this is a good guide, a good place to start. This is Shane has authored this book, which has a psychostimulant section. And that was my last slide. So thanks everyone for your attention.
Thanks so much, Julia. That was a really comprehensive overview of the issue. And there's a large number of questions here, so I'm not going to delay. I'm going to get straight into inviting Shane. Thank you. You've got your camera and mic on. Excellent. Welcome, Shane.
Hi, sorry.
Yeah, I wonder if you'd like to start and maybe just give us a few reflections.
I was just wondering if Julia wanted to stop sharing screen there.
Oh, yeah.
I'll do that. Yeah, I'll do that.
Yeah, look, it's great to be back in the ballrooms of Mars. Alice is looking beautiful. Look, that's great talk and such an important clinical issue, Julia, which is often sensationalized. It's great to get some just basic psychiatric facts about it. But two quick points I'd pick up on. First is the dose response and purity. When I was involved in setting up the illicit drug reporting system in the mid-90s, talking about amphetamine was the most boring thing because it was always the same, 7% pure, it was powder, and nothing much changed. And then in about 2001, suddenly it changed form, as you pointed out. Suddenly it was methamphetamine ice, 50% pure plus. This led to a spike in use, greater dependence potential. And when you have drugs with higher dependence used more frequently amongst more people and in higher potency, the risk grows, both in numbers to individuals and to society as a general. More people equals more harm. And in recent years, we have seen a similar increase in cocaine use, which was the other drug you referred to. Everything about it's interesting that meth just seems to be a more toxic drug. Cocaine's toxic, but meth, possibly it's got a longer half-life than many other things. And the second thing I just mentioned is the thing about vulnerability you mentioned. And this is true of both meth and coke. That you see the parallel there, people don't know if they're vulnerable. I mean, parallel there is I've done read thousands of autopsy reports on doing work on deaths for psychostimulants. And the parallel there is the accelerated cardiovascular disease we see there. 70-year-old hearts in 30-year-old bodies. And not everyone gets it, but some people do. And not only that, it can be very rapid. People could be developing a cardiomyopathy within 2 years of regular use of these drugs. And the reason I mention that is because this vulnerability is something that I think is crucial here. And basically, the more use of stronger drugs by more vulnerable people is going to place more people obviously at risk of psychosis and cardiovascular disease. And I'd just like to finish by pointing out, this is not to do with route of administration. These are drug effects.
No, that's right. That's right, Shane. Yeah.
We talk about opioids. A lot of things with opioids are bolus. It relates to drug toxicity. That's not different here. However you're using it, it's causing these effects.
Yeah,
so, yeah,
and that's also the same, Shane, prescribed or illicit, it's the drug effect.
Yeah.
Thanks, Shane.
Thanks, Shane. Great point. And I think there are a few questions in the Q&A around ADHD medicines, and you did touch on that, Julia. But I wonder, in relation to Shane's point around dose and potency, is there, with the dose of ADHD medicines being prescribed, how does that compare to doses that are used illicitly, and what kind of impact that has on the risk of psychosis?
Yes. Now, Alice, that is a really important question, which I have puzzled over for some time. And it's actually, interestingly, quite hard to get an answer as to exactly how much active drug there is in a point of methamphetamine. It does depend very much on the purity and the potency of a given batch. And I think it's difficult to really answer that question based in evidence. I think we know that lowered lower ADHD doses, particularly in younger people, you know, they're small doses compared to what an adult would have. But I guess the question is, once it's distributed in the body, you know, children and so on, it very much depends on the age, the body of distribution, volume of distribution. So we don't really know what level of the drug is getting, is having the effect. And again, we're not certain, I think, that drug at a certain level is for certain going to cause a psychotic effect in any given individual. As Shane says, you don't know your vulnerability until something happens. And I think clearly, if a child or young person develops psychotic symptoms on ADHD treatment, then the treatment should be discontinued. That's, you know, perhaps not very reassuring for people worried about the development of these symptoms. But I think what we know from Lauren Moran's study is that these psychotic episodes were detected in the first approximately 3 months of administration of the drug. But importantly, that was the period over which the trial ran. So we don't actually know what would have happened within the first year, within the first 2 years. It may be that if you're going to have psychotic symptoms, you get it quite quickly, but we don't know the answer to that. So I think it's important that people are aware that this can happen, and anyone being prescribed these treatments should be being asked about whether they're having any unusual experiences.
Yeah, great point. Okay, I'm going to get into the Q&A because there's a lot here, a lot of interest. So many compliments for you, Julia, for the great presentation. Now, there was one around visual hallucinations and how common they are in drug-induced psychosis.
Okay, that's a great question. So in psychosis in general, auditory hallucinations are by far the most common form of hallucination. You can have hallucinations in any modality: smell, taste, you know, the idea that we know about in drug work, that people can have the experience of sort of insects crawling on their skin, formication. People can also feel, you know, actually in their sort of sexual organs that they're sort of being interfered with. So you can really have a whole range across all the domains of the senses. Auditory are by far the most common in the psychosis population in general. Visual hallucinations are more common where there is some sort of organic contribution to the psychosis. That's true of drug-related and also people who experience psychosis, for example, in the context of dementia. So they're relatively, auditory hallucinations still the most common, but they're relatively, visual hallucinations are relatively more common in people who have drugs as part of their psychosis milieu.
Yeah, okay. All right. Okay, and a few questions about how to best help people who have, well, you believe they're experiencing drug-induced psychosis and maybe in some cases aren't aware of it?
Yes, so that's a great question. Clearly, I work in the mental health setting, and I think it's really important to acknowledge that how psychosis and drug-related psychosis is observed in a mental health setting is different to how drug-related psychosis may be observed in a drug setting. Because we naturally in mental health services are going to see the people who have the more severe psychotic experiences and full-blown episodes and long-term care. And that's how come they've come to us. People in the drug-related spheres, there may be the experience of psychosis for many people, but often they are, I think, considered to be a fairly benign consequence of use. I think what we can do in the drug-related setting, because this is actually where people can make a real difference to people and potentially prevent the onset of an ongoing enduring illness. If we can learn to talk a little bit more, explore a little bit more about the nature of the hallucinations or the odd beliefs or the paranoia or the seeing things or smelling things or people touching me. People talk about it being a bad trip. Is it just for a couple of hours, or are some of these symptoms present 3 or 4 days after use? Because that's starting not to sound like a direct effect of use anymore. Sometimes it can be really difficult to tease that out for people, for example, who have daily use of substances. What I would say, and answer it like a quick answer to your question, is ask, explore, explain that lots of people have these experiences. They can be very distressing. If you tell me a bit more about it, perhaps we can try and get you some help. We're trying very hard locally to work really closely with drug and alcohol to enable people to sort of get care across both drug and alcohol and mental health services. But this is a really long-standing issue in health service provision, that we become somewhat siloed. So I would say explore, try and be non-judgmental, try and help alleviate their distress, try and encourage them to seek help. I guess the first point of contact would be GP, ED, or direct referral to mental health services.
Yeah, excellent. That's really, really helpful advice. Thanks, Julia. Now we're running out of time, so I'm going to ask one quick other question, and that's around people using antipsychotics and
Yes.
what the risk is of further episodes, relapse, if they're continuing to use substances or even the same that they initially had were
Yes.
using, or something else.
So that's a great question. It's a question I often get asked, particularly by people I look after. Look, I've seen a whole range of things in clinic. I've seen young men who don't take their antipsychotics except the night before they're going to go on a drug binge, because they know that if they take the antipsychotic, the bad effects are a bit less. I've also seen very commonly people who say, it was the drugs that caused it. I'm not going to take drugs anymore. Don't need your treatment. What I would say as a general rule of thumb is that we don't really know what your future illness course is going to look like. But true of all people who have first episode psychosis, drug related or otherwise, we know that people who stay on treatment for 18 to 24 months tend to do better long term. We also know that if you are going to stop your treatment, it's much better to very slowly and gradually reduce the dose and monitor for re-emergence of psychotic symptoms during that time. So if someone really wants to come off their drugs, I would say, okay, but can we do it together and be transparent about it? Because if you just stop the drugs from that dose to zero, that actually, there's negative, positive feedback mechanisms in your neurotransmitters. It's unsettling and it may lead to re-emergence of symptoms. That's the sort of simple message. I wouldn't be prescribing antipsychotics for transient psychotic symptoms, which are a direct consequence of intoxication. If we're getting prolonged symptoms over weeks and they're distressing, that's the time to start having a conversation about starting an antipsychotic and stopping substance use.
Right, that's really helpful. Thank you. Now, there's a number of other questions that I'm really sorry that I haven't had a chance to put to the panelists. I do think there might be an opportunity, though, to highlight a resource that Shane has been involved in developing recently, which is a lecture series. Shane, do you want to give the audience a bit of a heads up about that so that they may go and find some further information?
Just on our website, we've got a series of 9 lectures on drugs in the body, and there is one on psychostimulants in the body, which includes all of the things that Julia have been speaking about today, and other brain effects, and also, but yeah, it's a series of 9 lectures. It's free, and they're fantastic.
Of course they are.
Yeah.
Excellent. Thank you, Shane. I'm sorry, everyone, we're going to have to wrap it up now. But I would like to thank Julia and Shane for the wonderful presentation and discussion. It's been really interesting and informative, and I think our audience has really appreciated your insights.
Thanks, Alice.
Thank you. And I'd like to thank the audience for participating, for being so engaged. Thank you very much. And before we bring the webinar to a close, I'll just let you know about our upcoming webinars. So next week, we have a presentation from Dr. Kylie Lee, deeper understandings of the patterns of drinking among Aboriginal and Torres Strait Islander Australians using the GROG survey app. And the following week, actually, I think I might have said it was next week. That's Thursday, 14th of September. So we don't have anything next week. The following week, on the 21st of September, we've got a presentation on the long-term patterns of heroin use and mental health, the main findings from the 18 to 20-year follow-up of the Australian Treatment Outcome Study by Christina Morell. So we look forward to welcoming you then. And yeah, thank you very much, everyone. Have a great afternoon.
Bye.